Hey, I'm Sarah Smith, family doctor, clinical day advisor, and the chatting coach. Welcome back to Sustainable Clinical Medicine podcast, where we're going to be interviewing peers or world experts who can help us think about our clinical day in a way that is more sustainable and create time for our lives outside of medicine. Hey, I appreciate you listening today. And just a reminder that if you go to chartingcoach.ca/giveaway, you could be in the running to win $150 towards one of our guest coach workshops. We will be drawing this every quarter. You only have to be in once to be in all 4 drawers. So don't forget chartingcoach.ca/giveaway. We'd love to celebrate you being a valued listener. Well, hello, everybody, and welcome back. Today, we have mother and daughter, Sarah Davis and Stephanie Davis. Welcome. I will let you introduce yourselves.
Okay, I'm Dr. Sarah Davis. I am a board-certified family medicine doctor, and I have been practicing concierge medicine in Dallas, Texas for the past 23 years. And one of my greatest claims to fame is my daughter, Stephanie.
Yes, I am her number one. Really, she's just my mom, should be her number one title. No, my name is Stephanie. I'm not a doctor, but I am a first-year medical student, so working my way towards being a doctor. I live here in Houston, started medical school this past August, and me and my mom host a podcast called Generations MD, where we talk about all sorts of things medical related. So yeah, I'm excited to be here.
Very good. And I'm delighted to see that whatever Sarah has done in her career has not put you off wanting to be a doctor. So I'm kind of curious about potentially what you saw growing up that made you interested in medicine.
Yeah, I think that that's a really good start into things because I definitely had a unique experience. Both my parents are doctors, but my mom has this concierge practice. So she was really able to be around a lot for all of the things, all my soccer games and cheer competitions. And she really set up her life so that she could have a family. So then when I was considering career paths, I was like, well, yeah, I'll be a doctor. Like my mom was able to do it all. Like surely I can too. Then kind of when I started learning more about it and shadowing other doctors, I was like, oh, wow, these people like, they don't have their lives set up in us in this way. They are working so hard. I definitely had an experience that a lot of, I call them like Nepo doctor kids, have is just the thing where my parents told me like try everything else before you go into medicine, make sure this is really what you want to do. But I'll say it's not like they really pushed me so hard to be like, don't do it, don't do it. And I had like 2 great examples of ways that they were able to have like autonomy of their lives and still be able to practice medicine, which is what they wanted to do.
Great. Thank you for that. It's always a nice reflection to talk to the people coming in after the first generation or the doctor. So that's awesome. Okay, Sarah, then I want to know, you created a sustainability within this practice from the sounds of it, but as a concierge doctor, you're often a solopreneur, like the only working doctor in the practice. And so therefore it's possible to overdo it, like have every aspect of your day taken up by medicine. So what did you do that created this?
Yeah, it is. It is very tricky to find a balance, and I would say concierge medicine is certainly not for everybody. You have to be somebody who can kind of figure out when it's time to really give it 100% and when you have to set those boundaries. As I said, I started my practice in 2002 when Stephanie was 1. And I had done a traditional practice before that, working for a big hospital system. And I did that for a little while and it was okay. But just like so many doctors that you talk to, I mean, it's not great for a lot of reasons. One of the reasons that I didn't like it was they kind of said, oh, well, we're going to let you just focus on medicine and we'll handle all the business stuff. Kind of like, don't worry your pretty little head about all of these things. We'll take care of it. And as we all know, it just doesn't work that way. All it means is that somebody else controls those things and not you. And so I quit that and was doing a little bit of part-time work and trying to figure out how to set up my own practice, because I figured, you know, when you're young, you're starting out, like if you're going to invest all of this in a practice, it's just nice for it to be yours, and being your own boss, if you can manage it, is, you know, I think the best way to do it. But and so there I was kind of with this, I had Stephanie's brother who was 3, Stephanie who was 1, and I had read an article about something called concierge medicine that somebody was doing in Seattle. And based on this article that was like 3 paragraphs long, I was like, you know, I think I'll do that. and I talked to various people, and everybody said, well, that's a terrible idea. You know, they all said, well, who's going to pay? Like, why would somebody pay for this extra thing when they already have to pay so much for medical insurance? And I said, you know, I just think that you can give people something that they really want. I think it will work. And then I just try to look at it in, okay, well, what would be ideal for the patient? What would be ideal for me? And then how do those 2 things overlap, so that it's going to work really well for both of us? And I did always think that I was going to have another physician in the practice. I named it Park City's Personal Physicians, plural. And so I still have the S on there, and it's still just me. Um, but I found that I was able to kind of do it all myself. And once you're in solo practice for so long, you just kind of get used to everything being done the way that you want to do it. And so the idea of bringing in another doctor seemed like that was just going to cause some chaos to the situation. But, you know, kind of the way that I have been able to do it is by, you know, having really upfront talks with those patients. I interview them before I accept them as a patient. I tell them what it is that I'm offering, what it is that I'm not offering, and just make sure that it's a good match. And for the right patients, they say, well, this is fantastic. This is exactly what I want. I want that personalized care. You know, the advantage is that I'm not seeing a zillion patients all day during the day.
Mhm.
The disadvantage is that I'm still on call 24 hours a day, 7 days a week, if they have an after hours emergency. Now, I do explain to them, I mean, if you need to go to the emergency room, you just need to go to the emergency room. You know, I'm not going to be able to manage your heart attack from from my home. And patients understand that, but they really do appreciate on a weekend they have a urinary tract infection, or you know, something that we were dealing with earlier in the week has gotten worse, and they call me, and there's things that we can easily do over the phone that I can do very, very quickly and efficiently, because I know the patients so well. I've known them for years, and what would take, you know, hours at an urgent care or an emergency room takes me 5 minutes. So the patients really do appreciate that. But it's a delicate balance.
Yeah. Okay. Um, but there's also things like overhead, rent, all the things that you're having to purchase to use during your workday, and you have to fund all of that. So
Yeah.
how did you think about that and structure that in a way that was sustainable?
Yes, that's a great question. Because one of the things that was expensive is I'm in a very nice neighborhood in Dallas. That was kind of an important part of my practice for the patients that I wanted. I really had to be in a neighborhood like that. And so my rent is very expensive, but I also don't need 5 exam rooms. So I was able to, the building was being built when I opened my practice. And so I said, okay, I just want 1,000 square feet, and was able to do that. And they said, oh, you know, you're going to need a bigger office someday. It's actually been the reverse. Honestly, I could go to a smaller office. The way things have gotten so much more automated, all of our equipment is smaller now.
Mhm.
I used to have all these paper charts I had to store, all of these things. So trying to keep overhead as low as possible on the things that you can cut corners on, right? So high rent area, but a small office space was important. And then doing lots of stuff myself. When I first opened, I had a receptionist, and then I was doing the kind of nursing stuff myself. Later on, I decided, I actually always thought I would need 2 employees. as time went on, I realized I actually only need one employee. So I ended up getting a medical assistant who does all of those things, does the receptionist, schedules patients, checks them in, gives shots, draws blood, all of that, which Stephanie actually did that job for a year in between college and medical school. So she got to see all of what that was. But having only one employee, so that's helpful. And then, but yeah, I mean, lots of other things that you have to kind of have, you can't have the super fancy EMR that costs, hundreds of thousands of dollars. But also in family medicine, we don't need tons of equipment. I think that's sort of a benefit of being a family medicine doctor rather than somebody who's like an ophthalmologist, where obviously they make tons of money, but they need lots of equipment to run their practice. Whereas, you can get by on other things and you can outsource lots of things. I don't need to have an X-ray machine in my office. They can go to the imaging center down the street to get those X-rays. But yeah, you got to have an accountant. You have to have, all of these different things, and you don't have any way of sharing that. But I think you just have to be very intentional on all of those expenses.
Yeah, and that would have factored into how much you had to charge patients and how many patients you were going to accept.
Yes, yes.
Yeah.
And that's
How
part of
easy is it to maintain that boundary with charging patients?
yeah, it's you really you just really have to figure it out. And it's interesting because you know, you charge a certain amount, and to some people that's a whole lot of money, and to some people that's not much money at all. They just spent that on a purse, and
Mhm.
so it's really, and then I have some patients that don't have lots and lots of money, but their healthcare is really a big priority, and so they're willing to spend money on that when they wouldn't spend that for other things, and so it's you just kind of have to say, like, they are spending this money, but they feel it's worth it. I feel it's worth it. And, but you can't, but just because they are spending this money doesn't mean that they get to completely abuse me.
Yeah, yeah, okay. Now tell me about when your MA needed holidays or you needed holidays. What happens on the times when you're not there?
Yeah, so we make it so that we're never both out of town at the same time. We kind of do our schedule. Oh, when do you want to be off? When do I? It's always tricky when I'm off. But I do manage to just do lots of stuff over the phone. And I used to have another doctor that we would share call. I would take care of
Mhm.
his patients when he was out of town. He took care of mine. But my patients never wanted to go to the doctor. So to somebody else, they would just say, oh, well, I'll wait till she gets back. So then I said, well, I'm not going to bother like taking his call if my patients aren't even going to use this when it comes.
Mhm.
So we just always managed to make it work. And I think people do understand that, I'm going to go out of town sometimes. And as long as I'm there for them most of the time, it's going to be okay. And again, my MA is here. She can still prescribe the medicines, but I end up being attached to that phone even when I'm on vacation. So
Mhm.
that's one of the things that again, it's not for everybody.
Yeah.
I will say, just hopping in, speaking on behalf of working as that MA
Mm.
job last year, hiring somebody that is really good and able to handle a lot of stuff is so important. She had somebody that was working for her for 20 years and then retired, and that person was just such a vital asset to the practice. So
Mhm.
I think, Mom, you would agree that having somebody in the office when you only have that one employee is important for that sustainability to be able to feel comfortable leaving town and not being in the office during a normal office hour.
Yeah, very true. It has to be something that the patients really like and trust, and that I like and trust. And so it is. And when you only have one employee, they've got to be really good.
Yeah. So Stephanie, what was the onboarding like? Did you get to talk to the retiring MA and work out the processes, or what happened there?
Well, the MA that was there before, she was the one nurse in my mom's office growing up. So I knew her very well, very
Yeah.
like,
She partly raised you.
Yes, exactly. So, and I just grown up around the office a lot. So I understood how the practice worked and everything. But had to learn how to do all the tech sort of stuff.
Mhm,
But I would say the biggest part of transitioning into a job like that is just being able to gain the trust of the patients and have
mhm.
and build those relationships because they are kind of going through you a lot. And if they don't trust you, then that's going to put a lot more burden on my mom, because they're going to go straight to her instead of, calling the office during office hours and stuff like that.
Yeah. How did you build those relationships? What would it look like for a new MA coming in who is not been around the patients for 20 years look like for onboarding, do you think, having done that job? What do you think was valuable in terms of making relationships?
I would say for me, it was that I was her daughter. So that was definitely gave me some credibility. And luckily, the one who I trained, the current MA, is just fantastic on
Mhm,
every front. So
mhm,
I think it definitely just takes a little bit of time. But also just trust in my mom that she's going to choose somebody who is good. I
mhm.
think that's how my mom has been able to build this practice is through those relationships, and it's multi-generational. So that I think it's really on
Mm.
you.
But
Mom.
it's a great question because it's still the you can train and train and train somebody, but there's so many different things. Again, it's family medicine. We've got kids, we have older people, we have all the, it's not like we have just one standard thing that we do all of the time. And so you have to have somebody that has just can think on their feet and that has very, very good, pleasant social skills. I realize
Mhm.
that is just something that is super important. They need to be able to read the room and figure out when patients want to chit chat, when they don't. And I don't know. I don't know that you can really teach those things. I'm not sure.
So they're qualities you're looking for that exist within that person, and then you can add the training on the tech stuff later. But
Yeah.
the most important part you were hiring for was that ability to understand what's required, that strategist, not tactician, the problem solver, plus some social skills.
Yeah. Yeah.
Yeah. I think
So
that's really important. And as we're looking around at the people within our office, we can start to identify who are those people? We know them well. And who are the people who can follow a list but aren't necessarily your front person, or don't enjoy the front because it's such an effort for them, it's not within their scope
yeah.
normally. Yeah.
Yeah.
Yeah,
How
also
did you? Yeah.
I
Sorry.
was just gonna add on to that and just say that like that is something, and having a good staff and hiring good staff is something that is really, really important, it seems like, in sustainability. And that's not something that we talk about in medical school really ever. We talk about working with, multidisciplinary team and all of that. But if you have your own practice, you're going to be hiring the people that are going to make or break your practice, really. And I think being able to tell and being able to interview people and know what skills to look for is not something that we really talk about.
Mm, got it. Sarah, how did you introduce your new person, and you've done this twice in 12 months now, I guess,
Yeah.
to your patients load, patient family? Did you have an email introduction? Did you have a welcome to the practice function?
I
What
did.
happened?
That's funny. I think we did an email. Stephanie, when you joined, we sent out a newsletter, didn't we? Did we start?
Yes. Yeah.
Yeah. And of course, again, that was easy. I send Christmas cards every year to my patients, so they truly have like watched Stephanie grow up. So they were very excited to have her. But then, everybody knew she was only going to be there for a little while, and everybody was so excited that she got into medical school. They were,
Mhm.
celebrating with us. And so then, of course, next question, all right, she's leaving, who's coming? And then I
Mm.
think I did. I think I sent out an email and just said, hey, here's the next person. And you guys have survived one transition. It's going to be okay. She is young and, a great employee and a great person. And so, yeah, it was okay. Again, some people respond much better to that than other people.
Mm.
And, but I think that they did kind of realize like, okay, you don't necessarily get somebody who's going to stay for another 20 years.
Mm.
Going to be
Yeah.
realistic.
Got it. Okay. So it's that succession planning. How many months of crossover did you have, Stephanie, and the new person working kind of side by side or together? What did that look like?
It was probably about a month, and then
Mhm.
kind of I slowly kind of faded away for another. So
Mhm.
probably like 2 months. Then I was kind of like on call if she ever needed
Mhm.
anything, any sort of little questions. A lot of the training was kind of as it came. Okay, how do you deal with this situation? And then if there was any sort of novel situation that came up a month later, then I was like, you can always text me about anything. So
Yeah, I think
Mhm.
we had actually planned on having more overlap, and then you were like, she doesn't need me. She's ready to
yeah,
fly
she
solo.
was great. Yeah, she was
And
great.
then Stephanie took off to Europe, so
I did.
Perfect. Okay. What does a clinical day look like for you then, Sarah, with what time do you start? When do you do your administrative work? What time do you finish seeing patients? How does it go? Give us a
so
daily.
my office is open Monday through Friday, 8:30 to 5. And
Mhm.
so my medical assistant is here during those hours. She takes a lunch break, in the middle of the day. And every day really is different. We have some things that are scheduled. Patient says, oh, hey, can I come in 2 weeks for my physical? So there'll be some things on the calendar, but people, because they can get in that same day for things, a lot of times people just tend to wait until that day, and then they'll call and say,
Mhm.
hey, can I come by for this or that? Sometimes it's something that's somewhat urgent. Sometimes it's something that has been bothering them for the last 3 weeks, and they happen to be in the neighborhood and said, can I come by and get this taken care of? So it is a little bit tricky. When I had kids at home, I did a lot of like going back and forth between the office and home. I mean, I
Mhm.
had a nanny when they were really little. Then once they were like school age and could be home by themselves, it was, some of just sort of going back and forth. I just had to really be available so that if a patient did want to be seen and I wasn't there in the office, that usually I could either pop on over and see them, or we could say, oh, can she see you tomorrow? So
Mhm.
but I end up, I see really a handful of patients in person, but then there's always lots of text messages, emails about things, following up of labs. Have my administrative stuff as far as I do, our billing, we don't bill any insurance. And so the billing is just me sending them a bill for their annual fee. And then
Mhm.
sometimes there's incidental things that I send them a bill for.
Mhm.
And I just use QuickBooks. I do all that myself. I balance my own bank account. I really stay very on top of all of my finances. I mean, I have an accountant that looks over everything, but I'm really the one doing the day-to-day tasks on that, but it's not that overwhelming. So, yeah, it would probably be better if I actually structured my day and said, okay, I'm going to do this administrative task from this time to this time. But I really don't do that. I kind of come into the office, do various things. Oh, wait, now I've got to go to the grocery store. Okay. And then I'll come back. And it's very up and down. But I'm not ever, well, right now it's after 5. This is like the only time I'm at the office after 5.
Got
Well,
it. Okay. Yeah. Yeah.
I'm not here on the weekends or after hours. And I do tell patients that I say, you can call me on the weekends after hours. I'm not going to come see you during those times. I said, I may not have a huge life, but I've got a little bit of a life. And so
Mhm.
I can't be just, picking up and coming here, at all hours.
Got it. Okay. So of the 8:30 till 5, how many pre-bookings would you limit it to if that is a factor in your consideration of your schedule?
So, I mean, it would, I, the other doctors that are listening to this will just, I mean, I can't even really say because it really is so few, but I really spend a long time with my patients. So I don't, I wouldn't have more than like 5 or 6 patients scheduled in one day.
Yeah.
Um, unless then I don't know if more people are needed to be seen that day, I would still be able to work those people in.
Mhm.
But especially if people are kind of saying, oh, I can come on this day or this day, and they're coming for just like a health maintenance thing, I would try to spread those out a little bit more, if
Mhm.
they're
Yeah.
so that I don't have, 10 physicals on one day.
Yeah, because that's the balance of the access for your patients, because that's what you had allowed them at the beginning. You're like, I'm going to be available. So that means you've got to figure out how you're going to maintain access for people for same day. And how are you going to offset the I want to be seen requests
Yeah.
from patients who want to have that scheduled appointment. And then that can become the new normal. If you do fill up, they don't believe you when they say, I want to be seen same day, and there's just no availability. So.
Yeah, and I just manage that by not by the number of total patients in the practice. My practice is very, very small. Even for a concierge practice, I have
Mhm.
roughly 100 patients.
Mhm.
And so a lot of concierge practices have quite a few more than that. And so, with 100 patients, it's really, it would be kind of crazy if like you really couldn't fit in somebody. Even if you were seeing 20% of your practice in one day, you could still do it.
Yeah. And I think that's really important for people to hear the panel size or the patient number that you've chosen, because it really shows the infinite possibilities here. So you're saying, I want to limit, or maybe you didn't say I want to limit to, but at some point you've decided 100 is a good number for you. And you said, 100 patients, here's my cost for the year. Here's how much money I want to take home. Here's how much tax I have to pay, and figure out what you're going to charge them.
Yes, yes. And that really is when I was first opening up. I mean, that is how I kind of just did the math. You kind of work
Yeah.
and you're like, okay, I have to charge at least this much. If I can't get enough people to sign up at that level, well, then the practice it's just not going to work.
Yeah.
You kind of have to just, and I do think that's a mistake that sometimes people make is that they feel like they don't want to charge that much. They feel bad, blah, blah. They charge too little. Well, then they can't give them the access that they promised them. And then then nobody's happy. So,
Mhm.
yeah, you got to do the math.
Yeah, got it. Okay. So doing the math, really important, but also opening your eyes to the infinite possibilities around medicine and how it could be structured for you if you wanted. Um, Tell us about the long visits and then the finishing off of that consultation. So getting all of the pieces of that consultation completed. How do you do that within your day?
Oh, so the long visits, I mean, the first 20 minutes, I've got to catch up on what their kids are doing and their last vacation. We've got to go over that. I mean, again, so many of these patients have been my patients for, decades now. And so there is a lot of that just chit chat that goes on, which is fun, which I really enjoy. So there's that part. Then there's, whatever problems that they're coming in for, whatever tests I'm going to order. I would say between me and my medical assistant, we do spend quite a bit of time and energy in coordinating their care. So if I say, I'm like, okay, I really want you to see a cardiologist for this.
Mhm.
Then I'm not just going to say, oh, here's the number of a cardiologist, call them. I'm going to schedule that appointment, or I'm going to text the cardiologist and have his office call the patient. I mean, and I'm going to know like that day, what time and what day they are going to see that cardiologist. And so that type of stuff, that coordination of care is like that's probably the most time consuming thing that I do, going back and forth on all of those things. And, especially for my MA, that's a lot too. She's got to do that follow up of sending those records to them and just, getting all of that organized. And then of course, the patient says, oh, well, I can't go that day. I've got a manicure. And then we've got to rework the appointment around this patient's schedule. No, I mean, most of them don't do that, but again, just, I mean, today a patient had, she had an abnormal mammogram, needed additional views, right? So in a traditional practice, you would just send an order in for that, and then the imaging center would call the patient and get it scheduled. And you would let the patient know, hey, this is abnormal. They're going to be calling you, and and a lot of times, just your MA would take care of that. For me, that's a phone call with the patient. We're going to go over that, make sure she knows that her mammogram is abnormal, but it's really nothing to worry about. And then we spent quite a while on the phone because they wanted to schedule her for 30 days out. Well, patients worry about abnormal mammograms. And so that wasn't good enough. We ended up going through a list of like 10 different places to finally get her scheduled, in a short time period. And the patient was very appreciative of that. And so that's the type of stuff that it ends up taking like a lot more time and energy. But, I think it's worth it. And I think the patients appreciate it.
Yeah, yeah. I guess this is part of that. If you were looking at what is the ideal that we're being taught as we come through medical school, which is your experience, Stephanie, you're understanding, you know exactly how to look after someone well. You know exactly how you want to deliver information and help them understand what's going on for them. But then we're given constraints within that corporation that we're working for, within the hospital system, within the appointment book for traditional styles of family practice. Do you have any reflection on the reasons why you had transitioned out of that at the beginning? And Stephanie, maybe even some reflections on what you're seeing as you're starting to be in that clinical space. The opposite of what mom's having right now.
Yeah.
Well,
Yeah. You go ahead, Stephanie.
I'll just speak a little bit on behalf of that. I even think about this when because I'm in the very, very early stages of
Yeah.
things. And, I'm not going in and seeing patients. I'm not doing rotations quite yet, but we are doing these sort of group activities where we're essentially talking about a patient's case and like how we're going to go through it and walk through it.
Yeah.
And they're like, okay, the patient comes in and they're having this issue. Like, what are the next steps? And everyone and all of my fellow peers are talking about, okay, well, we need to go do this full history. We need to get these like very invasive exam.
Yeah.
We need to do a biopsy. And and we're just like, well, like I'm just thinking, okay, in real life, we don't have time to do all of this. We're not gonna do, and I understand this is part of the learning process, but I feel like it's really not brought up a lot about like, okay, maybe this is ideal care, but let's think reality. Let's think about time constraints, finances, what's available to us. This is not something that is talked about that much.
Yeah.
So that's always something in the back of my head when even we're just talking about these sort of things.
Totally. Like when you're describing that, problem-based learning, we've got a case, we're going to
Mhm.
talk about it, we're going to do a deep dive in what this could be, what are the differentials, how are we going to solve that, how are we going to find the key features, how are we going to examine the patient, how are we going to tell the patient about this? And I'm like, yeah, this is what we're taught. This is how we're taught. This is what we want to do and what we love doing. And then whack, we're hit with the now try and put that in 15 minutes. Like it's not it's you're still being taught, and so you should be. How do I pause and find out what's happening? How do I help the patient understand what's going on? How do I help them with the next steps of their journey? Hearing that this is still the experience of medical school, right? This is still
Yeah.
what you're exposed to as you're training, and all of us have come through that in some way. It's still current, right? So that
Mhm.
let's pause and think about this patient for an hour. Um, for the next hour, 8 of us in a room. That's 8 hours of thought plus the number of hours of experience that we're pulling into this room for this one patient for 1 hour. So fascinating. Thank you.
Yeah, I mean, it's important with the learning process, and I understand, but at the same time, I do think it might be important to kind of still discuss these sort of things about how there is time constraints and how we can't just go do a bone biopsy right now. Like we don't have that option. Can we try to do cost-effective care a little bit? But I'm sure as I continue throughout my education, that's gonna come into play. So.
Maybe.
Perhaps,
Yeah.
but it'd be interesting to watch whether that does come into play. Yeah. All right, Sarah, your experience from going from one to the other. So tell us what was kind of challenging about where you were and what kind of made you start to be curious about options.
Yeah. It's good. I mean, it was honestly now so long ago that,
Yeah, I know
that
that.
um, but yeah, I mean, I do remember that just going from room to room to room, it's just your goal was to try to like solve that major problem and then just get out of the room and your hands on the doorknob. And then they're like, doctor, just one more thing. And you're just like, oh. So I remember how challenging that was. I remember, especially in residency, when we were dealing with a population that had very limited resources. I remember that being, just very frustrating. And, a lot of people that had very low health literacy. And so trying to just explain to them, some of the really basic things about what you were doing, was just, I mean, that was super hard. So I kind of went from that to then more of like sort of a mid-level practice, again, a busy practice, but, lots of different things. Um, Lots of different types of people coming and going, to then this practice, which is so different. I mean, one of the bad things about concierge medicine is that these people are used to the world revolving around them in a lot of ways. It's, especially you've got this high-powered CEO. He's used to the meeting starts when he gets there. They're just not used to waiting in a waiting room when you send them to the cardiologist. That's really so those things are challenging. But the flip side is, if you say, hey, do you want to get an MRI? I know insurance isn't going to cover it because this hasn't been going on for 6 weeks and we haven't tried this or that. It's going to cost $500, and they'll say, oh yeah, that's fine. Let's, I'll just pay the $500. So that is, I mean, that's such a privilege to have that piece a lot of times where you don't have to worry about it. You can prescribe medicines that are, quite expensive. And if, and you just explain to the patient, we can do this, this is going to cost a lot more. Either I think it's worth it or I don't think it's worth it. Sometimes they think it's worth it. But that's their decision. I don't necessarily have to fight with the insurance company over it because I already know the insurance isn't going to pay for this one. But if you want to pay for it, you can. So yeah, it is. I mean, it's a huge privilege to not have to have all of those fights that all of my colleagues in traditional practice are doing every day.
Mm-hmm. Yeah, yeah. What do you think some of the biggest challenges are if people are looking to move out of a system that's set up for them into their own practice in this
That's a
day?
great question. I mean, there's a lot of different challenges. I mean, I would say that, probably the biggest one is just the mindset. You know this system, and to kind of invent your own system is pretty tricky. I mean, again, concierge medicine wasn't a thing when I started. There was no roadmap. I just had to really completely figure out what that path was going to look like. And for a lot of people, that's just very uncomfortable, like, well, what's your day going to look like? When, what's this, how's this going to happen? How's this going to work? I'm like, I don't know, a lot of that, I'm just going to figure it out. And that's, and people would say, well, what's your target market? I was like, well, I kind of have an idea of who would benefit from this, but then I'm going to get there and then I'm going to find out who is sort of coming to me. And then you kind of keep going from there. So a lot of it's just the fear of the unknown. But then I think other things like, having access to working capital, so that, it is expensive to you've got all those startup costs. It's a while before that money starts coming in. So you've got to have some of that. And for, a lot of people, especially if they're just starting out and they have all this med school debt, it's pretty daunting to take on a big loan and start that again, especially if you're doing something that you don't have a lot of data to know what the success rate is if you're really trying to do something different. So I think those are big barriers. And then, and then just like Stephanie talked about, I mean, there's just so much in medical school that in residency that we are just not taught. We're not taught how to be a boss and how to run a practice. And, even sometimes they try to teach a little bit more like how to code better and stuff. But even a lot of those things, I just feel like didn't, I don't know, just wasn't emphasized nearly as much as some of this other stuff that like you could just look up. We don't, why do we spend all this time memorizing all of these different things that, I'm like, you could just look that up. Why don't we spend some time learning about how the system works and things like that? So
Tell us about what it would look like to move into your solo practice in terms of your baseline clinical knowledge, whether you've got colleagues to bounce things off, if you've got a patient that you're not really sure what you should do. Do you have in mind something that would help you understand when am I ready for solo practice, micro practice, what skill set, what knowledge base, how many years on the job? Is there anything that you've kind of had in mind that might have helped you to be ready?
Hmm. I don't know. I think a little bit of stupidity and overconfidence. Um, you know, sometimes you don't know what you don't know, and so sometimes you just have to like break out and try something. I mean, I almost think that like if I had done a traditional practice all this time and then thought, okay, now I'm going to break out on my own, I think that would be much harder to do at like I mean, at my age now, but also just knowing what I know and knowing how people do fail when they try new things. And I think that you can be your own worst enemy with talking yourself out of things.
Hmm.
Um, so yeah, I'm not sure I'm the best one to ask about that. I think I kind of took a leap of faith and it worked out, but I don't know that that's always the always the answer.
That's
And
certainly, yes.
I was just going to add that in regards to like being able to bounce things off of colleagues, you were able to make relationships with other specialists around the area, and you have people that you can text and call that are able to help you out when you have a patient.
That's true. That's true. I rely a lot on my specialists, and I luckily have found a very good network of lots of people who are very tolerant of my many, many questions. And I send them lots of nice patients, but I
Mhm.
also like text them a lot of questions in between, and they're nice to me, and that helps a lot with feeling confident.
Yeah. What about getting new patients? So if you wanted to increase your numbers, where would you do that? How would you do that in this technology's day? This
And that's a
day
tricky
technology.
thing as well. And I don't know that I know the answer to that. I would say my best patients always come from referrals from my current patients.
Mhm.
I've tried various marketing things over the years, and I would say most of them are not usually that successful. You've got you're up on Google, people can find you there. You can do various SEO stuff so people can Google concierge medicine near me and I'll come up. But um I would say, yeah, that's kind of like the best thing. That's where I get my best patients is just through referral from my current patients. So it's a little hard when you're first starting out because you don't have that first group in there. So I don't know if I don't know what the best answer is that for that.
What about things like patient stories, like the patient experience of concierge medicine? Have you ever used that in like social media or other ways to help patients understand what to expect from concierge medicine, how to engage with concierge medicine to help teach the patients who are interested in that type of medicine?
That's a great question too. I've just have not really done a lot of that. I mean, we have our podcast and and Stephanie's social media, but that's where, it's kind of a different thing. We really don't even talk about concierge medicine very much with that. I think all those things would be great. I mean, I could make videos and stuff. I don't know, in kind of this experience that I have, the new patients that I get are generally people that already know about concierge medicine. When I first started, that was really, I was up against comparing myself to an insurance-based model. Now, really, most of the people say, oh, yeah, either they're switching or they just moved here or something else. I mean, I'm sure there still is a big untapped market there of people that are still in insurance that are interested in concierge medicine. But I haven't spent a lot of time and energy trying to get those people. Um, Mostly just because I'm kind of on cruise control where I am. So I just haven't really needed to.
Mhm. No, fair enough. Stephanie, tell us about social media.
Yeah, I love social media. I think it's a great thing, and I definitely feel really strongly about encouraging people in medicine to use social media. I think it's a great tool to be able to reach just the general population of spreading knowledge and being able to counteract some of the misinformation that goes around a lot. I think that there's a fear definitely of like starting to post on social media and sometimes some risk about like maintaining like being professional, and maintaining your image as a physician while still being able to publicly speak on a platform. But I think that there's so many people that I look at, my classmates and other doctors, that I think are so well spoken and would be so good on a platform and deserve a voice. So I think that it's something I think people should do. I think it's a great way to grow your brand, grow your practice, and also just being able to share all of this knowledge that we're learning with the general population.
Okay. What do you teach people on social media? What is your area that you
Well,
like?
I don't know a lot yet. So
What do you do on it right now?
well, we have the podcast, which I love doing, and talking to doctors in different specialties and hearing their stories. Kind of a part of that is just sharing some knowledge for people in similar shoes as my own, like my peers, trying to figure out what specialty that they want to go to, figuring out lifestyle and those sort of things that we don't really talk about in medical school. We just kind of see, okay, what are you interested? Oh, you're interested in cardiology. Okay, you should be a cardiologist, not like what is the day in the day in and day out of a cardiologist look like. So I think that's important information to talk about. I also kind of, my TikTok and stuff is more just experience as a med student. I just kind of talk about my experience trying to shed a positive light on the whole thing. I think there's a lot of rhetoric around discouraging people to go into medicine, and we need more doctors. So I like to kind of try to, for the most part, show a positive side of things, and how I'm enjoying the path that I chose. So.
Well, you also did a lot of content when you were going through the application process with like telling pre-meds, like how she studied for the MCAT, you know, other things about, you know, all of the big complicated thing of applying to med school. And so I think that was helpful to those pre-meds as well.
Yeah.
Love it. Great. How do people find you guys if they're interested in learning more about what you're doing in your podcast, social media, or other things?
Yeah, you can find us on Instagram and TikTok at GenerationsMD. And if you have any questions about concierge medicine or anything that we talked about today, you can email us at askgenerations.md@gmail.com.
Perfect. Well, thank you so much. Is there any pearls of wisdom that we didn't talk about that you want to bring up before we close?
You got any pearls, Stephanie?
Unfortunately, I'm still learning the pearls. So
I guess just my little piece of advice is to you know, go for it, try to make your life as good as you can, and you can do that in medicine. You just may have to be a little bit creative.
Love it. There we go. Be creative. Have a little bit of an imagination around it. Take your time. And I love this conversation. Thank you so much, you two. Have a great rest of your week, everyone. Bye for now.
Thank you so much.
Thank
All right.
you.
Take care. Bye.
Thank you for being part of the Sustainable Clinical Medicine podcast. If you'd like to learn more or join us to help you get home with today's work done, go to chartingcoach.ca. There you'll find all the information on the premier Lifetime Access Charting Champions program that is helping physicians get home with today's work done, with all the proven tools, support, and community you need to create time for your life outside of medicine. We would love to see you there. Until next time, thanks for listening.